Hi, Dr. Alsaati.
Hey, hello.
Hi. I just made
Sorry,
you
I'm
co-host.
a few minutes late. I am so
Oh, don't
sorry.
worry. Oh, no.
I'm expecting another stat as well, so just
Oh.
but it's
Well,
okay.
let's see.
I'm covering stats today, so okay.
I see.
Let's see. I'm gonna share with you my screen, and you guys can see my screen?
Yes.
Okay, so as I promised, we're going to look at these two things first. So the first one is, remember the histoplasmosis case from yesterday that I couldn't find on my GMS stain?
Yeah.
Well, it was right there in front of my face, but I couldn't see it yesterday. But there you go. This is on low power, my GMS. And remember, that area is where the ulceration. I think what I did was I was focused on the ulcerated areas, and I missed the edges. And that histo is basically pretty much on the very edge. See that on the edge, and you can see all these histo.
Oh, yeah. Nice.
Yeah. So, which is a nice clue for us, and it keep reminding us that maybe the pathology is lost or the organisms are not too prominent in the fibrotic ulcerated area. So look around the edges. So this is the first homework for me to provide to you the answer. The other one was the ECL hyperplasia in AMAGs. I found this nice chart, the differentiation between hyperplasia into a preneoplastic process into a carcinoid or a neoplastic process. So the hyperplasia can be diffuse type, which is scattered, increased ECL cells throughout the entire stomach. And they're basically basally located. And those are, the patient with AMAG can live years and years and years with it, and it won't kill him. And it may or may not progress into a preneoplastic stage. So what defines this as, at first, we're gonna look at the simple diffuse type, linear and micronodular types, which are basically the most common findings. So just if you saw the simple diffuse one, for us, it's going to be very difficult to call this AMAG or ECL hyperplasia, because to my eye, I want to see the linear form and the micronodular form. That is more pathologic to us rather than the simple diffuse type. So when you see more than 5 ECL cells on chromogranin or synaptophysin, lined by next to each other, this is a linear type. The micronodular type, they are forming a small nodule or a micronodule, and the size of these micronodules should be less than 5 millimeters. And then you have the adenomatoid, where you have some rib reforming of these micronodules. The dysplastic type, which is the preneoplastic, is your micronodules are enlarging, but still they are not forming a 5 millimeter nodule. They are fusing with each other. They are microinvasive lesion, which is basically invading through the muscularis mucosae, but it's still small, less than 5 millimeters. Nodules with newly formed strata, that means that you have nodules. I actually did not understand this sentence very well. So if anybody has an idea to what that means, please share with me. But to a lesser extent, I think this is not something that I will probably lay my hat on. I'm not sure if I'm able to see what a new formed strata looks like. In any way, practically speaking, I want to see my nodules, my micronodules. First of all, number one, on endoscopy, it's forming a lesion or a nodule. Second of all, it's measuring more than 5 millimeters. then I will call it intramucosal carcinoid or invasive carcinoid. And the difference between them is the location. The invasive carcinoid is when you have the greater than 5 millimeter lesion invading the muscularis mucosae downwards, or the intramucosal carcinoma, which is you have a bulging or a diffuse pattern of small carcinoid tumor involving the lamina propria and not going all the way into the muscularis mucosae. The case that we looked at yesterday definitely was an invasive pattern of carcinoid. It was big, it was large, and it was into the muscularis. But it seems like he shoved the whole thing. It looks like the margin was negative on this case, which is another important thing to mention when you go ahead and write in your report. All my cases, if I have a well-formed carcinoid, I would definitely do a Ki-67 to kind of grade it properly, which is pretty much grade 1 if it's mitosis less than 2%. All right, these are the two things that I think we had to go over before I move on with continuing our case.
Dr. Alsaati, do you ever see only hyperplasia and not autoimmune in the background, like other features of autoimmune gastritis like atrophy and metaplasia is not there, but only hyperplasia is there? Do you see that? And if you do, then how do you report that?
So I will only call hyperplasia if I do chromo and synapto. I don't usually do it if I don't suspect it. So if there's cases of hyperplasia, then I missed, because I only do it when I suspect it. Could there be ECL cell hyperplasia? Yes. The reason is H. pylori can cause that. Okay. But it's not to the extent that I will form chromosynaptome. It's not, actually, in fact, when I was preparing for today about this ECL hyperplasia, it was very interesting that why do we have atrophy in patients with H. pylori? And I never kind of thought about it deeply, but I came across an article, not an article, I don't know where I was reading. I was reading somewhere that there is antibodies against H. pylori are identical for the antibodies against the parietal cells or the intrinsic factors. So that's why we have a similar picture in both. So it kind of made me like so interested about this topic, because why would I, like literally, I've never understood why would H. pylori cause the same thing? Why would it cause ECL hyperplasia? Why is it just so identical to AMAG? And things like it's just the antibodies against the H. pylori infection will, so the intrinsic factor and the parietal cells are the innocent bystanders in H. pylori. That's how we can put it together. But yeah, so to answer your question, ECL cell hyperplasia can be found without AMAG, but do we stain for it all the time? No. Is it significant? Absolutely not. Okay, not significant at all. All right, moving on. So somebody needs to help me remember where we stopped yesterday. Do we remember?
Third page Giardia.
Sure, third page Giardia. So carcinoid, lyocarcinoid, eosinophilic, acinar. Wait, let me see, maybe I have this here. So I'm gonna just refresh my page.
No, it's the third page that you have.
Okay, so third page. Meckel's ectopic gastric duodenum with the that carcinoid, acinar. Enteropius, pinworm. Well, no, I'm pretty sure.
This one's down. No, we didn't do. We did do pinworm, no?
It's okay. So we did, I'm sure we did eosinophilic esophagitis. We did adenovirus.
Oh, here it is. Here it is, Giardiasis. You see the normal formation.
Okay, yes. Okay. All right, now we're gonna do the fully developed screw-like changes, okay? And I see they have two images here. And I'll open both to see if they're both H&E. Yeah, and they're both H&E and they're both actually, no, they're not the same. Okay, so he has two examples. So let's see, low power. If they told me this is duodenum, what triggers me to get very intrigued here is I don't have villi. You know how the duodenum, we have lots of nice, very elongated villi. the distance between the base of the villi and the villi that is protruding outside should be 2/3 out, 1/3 in the lamina propria, which becomes a pit. For here, I have nothing out. It's all blunted, okay? So first thing in my head, first thing is the patient, where is my stomach biopsy? Does the patient have H. pylori, okay? Second thing, does the patient has diarrhea, bloating? Okay, so these are all, I'm trying to connect the dots before even going high power on my slide, okay? Third thing, I look for activity. Okay, now I know I have blunted villi. I go higher power and I keep going higher power and I see that there's innumerable lymphocytes, okay, in all my mucosa. See here, let's say, okay, here's my 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. So if I am really in doubt, I want to see more than 5 lymphocytes in my tip of the villi. Number 1, I have blunted villi. Number 2, I have increased lymphocytes. Okay, so these are the 2 things that you want to put. Would you call this celiac consistent with celiac disease? Absolutely not. You have to give a differential. Okay, so what I say here, GDL type mucosa with blunted villi and increased intraepithelial lymphocytes, see comment in my comment section. In the appropriate clinical settings, this could be seen, and this could be a classic feature of celiac disease or celiac sprue, which is marks, and if whether or not you want to classify it, it's up to you. Some doctors don't ask for classification, the Marsh classification, which I really don't recommend you guys go into it because not everybody believes in it. But this is completely blunted, and then serological correlation is recommended if not already established. Okay, so he needs to look for his serology. The other case is this one. Wait, if I close this, nothing will happen. Yeah, and the other case is this one. Let's see. What do I have here? I have gastric foveolar metaplasia. Okay, let's see. I want to make sure that this is not, yeah. Wait. Makes me think that this is even a stomach biopsy. This is the patient's stomach. That same patient, they gave us the stomach and they gave us the duodenum. Okay, right? Because I mean, the first thing I said, okay, am I looking at a stomach? Does the patient have metaplasia? No, this is basically the patient's stomach. He's showing us that the stomach is inflamed. Let's see if we have H. pylori. I don't see H. pylori on this patient on H&E, but it's good that he gave you the stomach. That's a good lesson for everyone. The reason is always look at the patient's stomach when you're, come on in, just a second. Yes, is that the staff? Okay, thank you. Always look at the patient's stomach when you're going ahead and ruling out celiac disease. And honestly, I'm trying to look for H. pylori. It's so inflamed, but also inflamed gastric mucosa can be in patients with celiac disease, okay? Chronic gastritis can also be seen in patients with celiac. And you see how there is like some reactive gastropathy here? It's corkscrewing of the antrum. All right, so, but nothing much. I will leave it as celiac, suggestive of celiac disease, and there are mild chronic gastritis with reactive gastropathy in the gastric mucosa. All right. I just got my stat. Akansha, would you want to go one more case and then I'll just take a quick look and then I'll come back?
Sure. Let me.
Thank you. I'll give you. I will. I'll mute myself. I just need to take care of this. Okay.
Sure. Yeah. Let me share my screen. Okay. All right. Screen. Yes. So we are in. So we were on page 3. Screw-like changes. Okay. All right. So inflammatory cloacogenic polyp. All right. So what are we seeing here? There's almost like granulation tissue kind of changes in that one. I'm sorry, I won't be as good as or any good as Dr. Alsaati, so you have to bear with me. What else? Yeah, so all I'm seeing here is this this vascular ectasia and this granulation tissue type things, and then these like those smooth muscles that Dr. Alsaati talks about in the in the in the lamina propria and in the beneath that. So that's what I'm seeing over here. I think that would be consistent with the cloacogenic polyp.
Akanksha, I was just reading on PathOutline the findings. Let's just correlate with this slide.
Yeah, that's actually a good idea. Let me open the path outlines too. Yeah, that's a good idea. So, all right. So tubulovillous elongated irregular crypts extending into the submucosa, squamous colorectal or transitional epithelium eroded at the surface. So that's what we saw. The colorectal was eroded at the surface, covered with the exudate. So that's like more of granulation tissue in here. Hyperplastic regenerative changes, we saw that. So it was there. And thickened muscularis mucosa, that's what we said, the irregular strands penetrating the lamina propria. So we saw that too. I'll show again. And then no dysplastic changes, no desmoplasia, no invasion. So basically, apart from what we saw, there was more of hyperplastic and regenerative changes in there as well. So let's see. Yeah, so these muscles that are in the lamina propria, that's one of the features. And then the hyperplastic changes that they are talking about. So there's all of these hyperplastic changes, no dysplasia. You can see the hyperplastic changes nicely over here. No dysplasia. And then there's some ulceration. There is some granulation tissue formation right here. So that's another feature. If anyone sees anything else that they want me to focus on, just let me know.
I think the main differential is cystitis cystica for it. And then I think to differentiate it, it is more tubulovillous. Like this entity, I think, is tubulovillous. And that won't be with hyperplastic changes. And that is more of a prolapse kind of change. This has prolapse tube along with the tubulovillous change.
Yes.
Right. Okay. Do you want to add something, Dr. Alsaati?
Cystitis cystica is pretty much deeper. This one you can tell that the pathology is all on the surface epithelium. Erosion or not can or cannot happen. Just imagine that there is a mucosal prolapse at the junction mucosa of the rectum. This is the fancy word for it. It's nothing else, okay? So it's prolapse and the muscle is going up there and it's pulling around the glands. But that's it, nothing else. There is it's a very, very, very common diagnosis. I probably do 5 a day from this. Okay.
Okay, so I'm stopping the share. You can share.
All right, let me go and share mine. All right, so you can see, right?
Yes.
Okay, so
we did the cloacogenic. Now we have the acute infectious colitis, the one that is already clicked in yours.
Okay, acute infectious colitis. Okay, perfect. So before even I look at my screen, when I have an acute infectious colitis, I should not have chronicity, okay? So on low power, this is a low power diagnosis. You look up there and you see all the tubes are lined up properly. You don't have basal lymphoplasmacytosis, okay? So I'm kind of having a picture of, okay, whatever the pathology is, it's recent, it's not chronic, okay? So now I go high power. All right, let's see. I have cryptitis, crypt abscess. Okay, now I look for granuloma. The granuloma is a feature of chronicity. You cannot always see it on low power, so you need to go high power. And sometimes crypt ruptures can cause granulomas on the side. Don't confuse it to a chronic granulomatous colitis. Okay, so here I have nothing. I don't have granulomas. What else should I look for? I look for CMV inclusions, okay? I know that I have activity here. The first thing you want to rule out is CMV. See how bad this activity is? All around. All of these are active colitis within the cryptitis, active cryptitis. Okay. What else? Pretty much once I make that diagnosis, I stop and I rely on my immunostains. I need to do a CMV. I look at the surface if I am missing some sort of parasite, which I'm not, hopefully. But that's it. That for me, this is active colitis, moderate. That's how I would call it. I sometimes call my active colitis, focal patchy. It depends on whether or not I have all my groups versus some of them. And it also kind of tells you, hints you for the pathology. If you have patchy, it could be more of a drug-related injury. If you have continuous, it's probably an infection or a patient who is undergoing evolving IBD. Okay, so let's see if we have another stain on him. Nothing. So this is, no, well, that's the same case, right? Yeah, that's the same case. Okay, so moving on. Cribriform comedo-type adenocarcinoma. Okay, so that's in the colon. So let's see what we have here. Okay, it's nice confirming that we're in the colon. Beautiful, beautiful. This is all colon. Sometimes we get only what we have here. You have normal colon on top, and then you have invasive adenocarcinoma, comedo-type, or see how it's all kind of acinar shapes. And if let's see, I don't look at the whole slide. I only have this area. Somebody's making some noise around. Do you want to mute them or something? I don't know how to mute.
That might be me. Let me mute myself first.
Okay. Sorry, Akansha. Okay, so this is for when I see this, I definitely want to rule out a carcinoid. Agree? Because there's a lot of ductal formation, tubular formation. I want to rule out carcinoid in this one. So I will definitely do a chromo or a synapto. But luckily, we have more than that. We have the entire tumor here. We have the entire surface, and then we're going down here. So we have basically a surface dysplasia as well, high-grade dysplasia. See here the continuity between the normal, and then boom, the dysplastic process starts. I would definitely do MSI panel on this one because this is one of the features with the increased TILs, tumor infiltrating lymphocytes. I would also think that these are the types of cases that are MSI unstable. So they are MSI unstable, yeah. Okay, so this is how it is. You see here the muscularis. Okay, so you have to know the difference between the muscle layers we're dealing with. The first one is right there. When this is my muscularis mucosae, and this is my submucosa, and this is my muscularis propria. My tumor has already gone through the muscularis mucosae. It cut through these bands of muscles, and it was involving the submucosa with abundant desmoplastic reaction. And guess what? It's going out into the muscularis propria. Okay, so it's crossing through here. There is nothing, there is no significance where the tumor is once it's in the submucosa. I don't care whether it's touching this muscle or here. It doesn't make any difference for us clinically. The only difference clinically it makes whether or not it crossed my muscularis mucosae. okay? Everything beyond that point is dealt with the same, all right? So we'll deal with this as invasive adenocarcinoma, of course. This is not a biopsy, this is a resection specimen. So for the resection specimen, we definitely need the serosa to see whether or not it's involved. We need to see the distal and the proximal margins to get a complete report. Okay.
Dr. Alsaati, can you tell a little bit about tumor budding? It's kind of optional in the CAP template, so some people report and others don't.
Yeah, I am not one of those who do tumor budding. But let's see, well, let's go back to it. Okay. Okay, so 1 second. Okay, so for tumor budding, you should have those small clusters of cells, the tumor cells that are growing out of the tumor. So they're not continuous growth, they bud out, And that's where the controversy occurs. That's why CAP doesn't have it as one of its criteria, because some people will tell you, oh, it's still, there is a connecting desmoplastic reaction between this tumor and this tumor, then it's connecting with this, then I'm not going to consider this a bud. Okay, and so for instance, so they want the tumor to be completely out. It's like almost, it's not connected to the actual tumor. So these three might be tumor buds, but it's a soft criteria. It's not something that everybody will give it a lot of attention. Okay.
Thank you.
Mm-hmm. All right, next is Microvilli inclusion disease. Oh my gosh. Let's see. Maybe I will learn something today with you girls. Microvilli inclusion disease. Okay, let's see what the other stain is, because it could be a PAS or something. Oh my God. Yes, it's the PAS. Okay. Okay, not something that is commonly seen at all. As far as I remember, it's a neonatal. Let me see, I'm gonna open pathology outlines because it's not something that I am used to, but I think it's pathology outlines. As far as I remember, they do CD10 and they do PAS, okay, so congenital congenital or familial microvillus atrophy. Yes, now it's coming back to my head. Okay, it's the intestinal brush border that causes intractable watery diarrhea and steatorrhea in infants. Patients require total parental nutrition and live up to 2 years of age. Villus atrophy may be due to apoptotic cell loss. Did you guys have any case like that during your residency or fellowships?
I heard of it for the first time.
No. Here's CD10. Here's CD10. So when I was at Georgetown, I think we had a case. That's why it's coming back to me. I was probably a first-year resident, let's say like 8 years ago. And we had a case that I remember I did a CD10 and the PIS, of course, with my attending. And I kept looking at my stains and it didn't make sense at all to me. I just something didn't click. I was a first year and I think my mind was so primitive that nothing could come. Are you guys seeing my screen?
Yes.
Okay, you see the
Microvillus atrophy.
Okay,
Yeah.
okay. Yeah, so I want to see here. So the pathology in microvillus inclusion disease is basically the epithelium or the brush border of the small bowel is no longer present. So when the food particles or anything needs to come through, nothing is absorbed, okay? And because nothing is absorbed, the patient will have almost as if doesn't have any small bowel, and he'll have diarrhea, steatosis, and all of that. How to diagnose, okay? So you can see at the picture here, there's a control, which you have a nice, beautiful CD10 at the bottom, just highlighting the brush border, and a nice PAS, highlighting only the brush border, and there is no PAS inclusions within, PAS positive inclusions within the columnar epithelium, okay? Now let's look at the disease itself. The disease itself tells you that instead of having that line, single linear line of the PAS positive microvilli, you have a band or thickened inclusion-like filling on top of the entire columnar epithelium. And it's highlighted with both with CD10 and PAS, okay? When I read about it, I remember, oh my gosh, you're bringing back so much old memories. I remember that the pathophysiology in this one, it's either the brush border started to happen, and then there is a pathology that all these villi from the top, they will be apoptotically circled and going back down into the columnar epithelium. Okay, this is one theory. The other one was during development, the microvilli basically developed from downwards up to become in the surface. That's congenitally, like that's embryologically. And that theory would tell you that it is failing to reach the top. Okay, so which one is correct? I have no idea. But for you to understand, you have to know that microvillus inclusion, that means the microvilli, instead of being in the brush border, they are actually inclusions within the columnar cytoplasm, okay? And it causes diarrhea, parenteral nutrition. You have to put the patient on TPN, and they will need small bowel transplant. Feel free to read about it and correct me if I was wrong, but this is what I remember from my residency. I, of course, haven't had a case. It's very, 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 very rare. The one case that I had at Georgetown turned out to be not a true microvillus inclusion. So we did all the stains, nothing made sense, but it wasn't a classic case. So we did not end up calling it microvillus inclusion. But I remember reading about it. So everything you read during the residency will come back, even if it's 11 years or 10 years old. All right. Let's look at his case though. Okay, if he's calling it microvillus inclusion, then we should be able to call it. So first of all, it has to be small bowel. And you can see that is all Paneth cells in the bottom. And you have to have villi, and the villi should have brush border. I really don't know what to say, but it's kind of very difficult because I have villus blunting for all of my small bowel. And of course, because of that, and probably the patient, we have to think about it. The patient does have signs and symptoms, and the doctor will tell you, please rule it out. That's when you do your PAS, and you see your PAS, instead of being a linear line on the surface, it will be all thickened line and thickened inclusions within the columnar epithelium. See how you have, instead of having it, so these are the nuclei. This is the columnar epithelium, and this is the what's so-called supposed to be a brush border, and your PAS should only be positive at the top. Instead, we have it a band, thick like band, like thickening of the entire I don't know. I feel like this is how I'm gonna describe it. I'm gonna move on because it's very rare and I haven't had a case ever in my life.
That is such a cool case. I'll always remember this one.
Yeah. And you know, the more you like, here's the path outline. See the path outline, the PIS stain? Instead of it being just a band, like a linear line, it's like a band like. Okay, cool. It's good to know that this this disease exists, first of all. Before. Okay, so appendix enterobius vermicularis, a pinworm of the appendix. Let's see what we have on H&E. There it is. No, let's see, here it is. Oh, okay. The way we know it's enterobius, you should have one flatter line from the eggs and then rounded from the other. One flat, one more rounded. So it's not pretty much oval, it's more flattened on one end. The more you see of these bugs, you will become experts at it. I hated grossing them. Really, it's disgusting. See, of course, what do I not want to miss? Carcinoid. This is a nice ganglion. See that? Within the muscle. So this is just fat. You don't have to worry about goblet cell carcinoid, but always, always look at for carcinoid at your tips. Okay, next is Wilson's disease. No, that's pancreas. I'm not going to do it. Cowden polyp, Cowden syndrome. Okay. Did I ever make that diagnosis? No, I haven't. But classically, you'll have cystically dilated glands like that. The patient will have genetic mutations for Cowden syndrome. What else do we have? Almost like a hamartomatous polyp. You see like that spindle proliferation within the lamina propria and hyperplastic change and surface erosion sometimes. Let me see if I'm missing something. The cases I had from Cowden was the patient came with the diagnosis with Cowden syndrome. Let me see if I am missing some criteria. Okay. So non-dysplastic epithelium, dilated glands, expanded stroma, histologically similar to juvenile polyp, may also show intramucosal lipomas. And the picture they have is this one. Yeah, I mean, it's totally juvenile polyp or retention polyp. So nothing too fancy to add. They said you might find lipomas, so let's see if we have something here. Would you call that? Not sure. I don't see nuclei in there.
Yeah, you don't need to have lipomas at the same place, right?
Yeah.
It can be anywhere.
It can present, but it's nice that you have cystically dilated glands. Always when you have cystically dilated glands, you have to trigger in your mind, am I dealing with a hamartomatous polyp? Okay. All right. Next is collagenous colitis. I have a nice case today of that as well. So let's see. I'm pretty sure they have the trichrome there. Let's see if that's, yes. So, okay. So we have both the trichrome and the H&E. So what strikes me, oh, first of all, sorry, I know I have to describe it on low power. Low power, I have nice appearing tubules. I don't have chronicity changes. The lamina propria is busy a little bit. The epithelium is slightly sloughed from the top. So I might have active colitis, and I'm just making my suspicion. I might have active colitis, but I also cannot rule out microscopic colitis. So I will go high power, very striking, very thickened collagen band. And then I go here, again, more collagen. Sometimes collagen can be expanded when you're on the right side of the colon. So it's very good to know where you are. Second of all, when I'm looking at my collagen, I look for a vessel, okay? Because if it's a true collagenous colitis, the vessel will be surrounded with collagen. If it is not a true collagenous colitis, the thickened collagen band will spare the vessel, okay? It will go from on top of it and push the vessel downwards. But if it's wrapping around, then the pathology is involving the vessel, okay? That this is an actual collagen disease. This is a criteria. Keep in mind if you are whether or not thinking of it. Look, more. See how the vessel is surrounded with collagen as well? So what do I have here? I have, even PPRI. You see how there is increased lymphocytes? So you have increased lymphocytes, you have thickened collagen bands, you have denuded mucosa or sloughing of the epithelium, which is another criteria that can be seen. Don't be surprised, but sometimes you can see active colitis, okay? So you can see scattered neutrophils, which is fine. It doesn't change your diagnosis. It's still collagenous colitis. Your diagnostic line with or without trichrome should always be collagenous colitis. You do not, this particular case, you don't need a trichrome scan, okay? This is very thickened, very classic. I don't need anything. I have all the criteria to call it collagenous. But luckily we have trichrome. And look how the trichrome is very beautiful. It shows thickening and it's diffuse thickening throughout all my, where did I go? Throughout all my parts. It's starting from here, it's thickened all the way up, and it's on all the pieces, okay? Let's say you have patchy increase, you have patchy thickening, and your trichrome didn't help as much. And you feel deep inside this could be an evolving collagenous colitis. What would you say? You would say fragments of colon mucosa with patchy thickening of the collagen band and increased intraepithelial neutrophils, lymphocytes. And your comment would say, this may be seen as a result of infection, resolving infectious colitis, could be a drug-induced injury, it could be a biopsy next to a diverticulum, but also could be an evolving or emerging microscopic colitis. I will not differentiate lymphocytic from collagenous if it's not 100% accurate. So I will call it emerging microscopic colitis, not collagenous, not lymphocytic. Because very, very common, I have seen cases switch back and forth between the two diagnoses because you have features of both. Okay, questions?
Dr. Alsaati, can collagen be confused with the erosion with fibrin deposition? I mean, trichrome would help us, but if like without trichrome, can we I know fibrin is little, collagen is little dense, but does it ever confuse?
Yes, of course it does. It does. So my criteria to call collagenous colitis, it has to be a random colon biopsy. If the doctor is taking it from an ulcer or from an erosion or from a bleeding area, I will not even come close collagenous colitis, okay? So my biopsy has to be random to the clinician's eye. It has to be a normal appearing colon, okay? That's when I am sure that my trichrome is pretty much doing collagen. Now, fibrin is not trichrome positive, okay?
Yeah.
So lots of, trichrome can help you. Trichrome can really, really help you when you are in doubt, okay? And don't bother doing it if you see active inflammation, ulceration, and fibrin, okay? Because sometimes as a reaction, you will have elastic band thickening or collagen band thickening as a reaction to that polyp or to that erosion. And you don't want to get fooled and call this collagenous colitis while it's just a reactive process, okay? Even if you have thickened collagen band at this point. But the thickening of collagen is basically due to the pathology of an erosion or an ulcer, okay? So if you are in doubt, always call treatment, or after healing has subsided, please bring the patient back in 3 months, blah, 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 because given the patient's clinical symptoms of chronic watery diarrhea, an emerging microscopic colitis is in the differential, something like that, okay? Try your best in your reports to be very openly open conversations with the clinicians, like bring him back, let's do this, treat him first, and let's look again. They will be very appreciative because they're also very tired of having the patients coming back multiple times with no improvements in symptoms. Okay.
Thank you.
You're welcome. And so these are the two. I'm gonna close this and I'm gonna leave my pathology outlines out there. Perforated esophagus in a background of eosinophilic esophagitis. So I'm assuming we have a section, not a biopsy. Yes, because why would I call it perforation on biopsy? So what did he see? He saw eosinophilic esophagitis. No, wait. Yeah. Okay. I think nobody has any doubt that we are dealing with eosinophilic esophagitis here. We have increased eosinophils. We have my 3 criteria, the eosinophils, and we have the basal cell hyperplasia, and we have the spongiosis, right? We went through that yesterday, and I want to confirm that it looks primitive to your eye first. It has to look dark and primitive. Almost you're looking at a basaloid, some basaloid skin tumors, but that's not the case. It's just basal cell hyperplasia in eosinophilic esophagitis. And look how beautiful you have eos going down into the muscularis. And this is another classic sign of eosinophilic esophagitis. So he is saying there's perforation. So let's follow. I mean, perforation is definitely not a diagnosis that I would do on my biopsies, but if he is saying there is perforation, then probably there is. And it's, I don't know, it could be that area here. But the section is not the best to my eye, but there's lots of bleeding. There's fistula. See that area here? Likely this is the perforation.
Does it have foreign body giant cell reaction? Then we can call it.
Let's see. There, I don't know. I don't know, but to me, it looks like this is the area of concern, but definitely I have to correlate with the gross description of the specimen, right? But why not? It does show me that you have thickened muscle, and it does show me that the epithelium is interrupted, because this area here, this one, this group is okay to me. This group here, it seems like there is some pathology at this point. Okay, so this could be the area of perforation for the patient. Okay. Inflammatory fibroid polyp. Nice, nice, nice. So inflammatory fibroid polyp is a polyp of a stomach, of course, and it's a diagnosis of the lamina propria. And then you have to go there, you have to see muscles, you have to see eos, okay? And your main differential diagnosis is inflammatory myofibroblastic tumor. And the way you differ is the myofibroblasts, which we don't see here. We see only the fibroblasts and the eos. It's a very common diagnosis we see all the time. It's of no clinical significance, and you will just call it, see here, you have dilated vessels, you have eos, and you have the scattered muscularis mucosis. So it's almost like a prolapse change of the muscle. But that's pretty much it. Always, always don't forget to screen your epithelium for intestinal metaplasia and your lamina propria for signet ring cell tumor. Because on low power, if anybody told you a stomach, say, why is this so expanded? Okay, you go higher, higher, higher. Look for, first thing you put in your mind is tumor, is looking for poorly differentiated carcinoma, which is not the case. It is a classic inflammatory fibroblastic tumor of the stomach. Neuroendocrine carcinoma, small cell type, high grade. This is pancreas, rectum, ulcerative colitis with high grade dysplasia. Oh my gosh. Okay. So UC is basically looking for chronicity. So I'm going to look for chronicity changes. Or it could not be chronic if the patient is well treated and I'm not worried about active colitis at this point, which is probably the case here. I see a lot of small lymphoid aggregates. In the rectum, I don't have any crypt distortion or glandular disarray. So for me, this is not a high-grade lesion. I'm sorry, an active lesion, active disease. Now I look here, I see nothing at all that tells me that this patient is a UC patient, okay? I mean, this could be just a random tubular adenoma in a random person, right? Agree with me? I don't see anything that bothers me. But of course, the history tells me that the patient has UC, so I have to be very careful. Now, the doctor, did he see a lesion? Did he see a polyp or not? Because that will change my diagnostic line. And this one here, you see this here? This is low-grade dysplasia. See that? This all is low-grade dysplasia. And it's multifocal, like it's multiple patches of low-grade dysplasia. And then I go higher here, and then this is a very detached fragment. This one, I don't know even if it's a floater from a different sample or it's from the same patient. Okay, it's detached. I mean, I deal with floaters all the time. So it's a lot. If this is not really touching that, I'll wait, I'll look at it at the very end. Okay. Only low grade, only low grade, only low grade, only low grade. I'm not worried about high grade yet. Am I going too fast? I don't have anything here, but we are going to look at this again. So it seems like he's worried about this part. I can't, ladies, I cannot call this high grade. I might be wrong, but I can't call this high grade. It's too inflamed and I don't have crib reforming. I'm not very comfortable calling this high grade. And here, the area, this to me is all low grade. This whole thing is all low grade. The other area of concern is this guy. Okay, well, maybe I have crib reforming here. I will do a level and see what happens to this group. But, you know, giving a high grade diagnosis to a patient is just telling him to go ahead and take his colon out instead of screening every year and so forth. So it's a big diagnosis. And if my high grade was floating here, I don't know. I mean, this is not even a high grade for me. So I'm having a hard time with this case, calling it high grade. Not yet. Not yet. Okay.
It's a lot of intra-observer variation too, like
yeah.
whatever they thought.
Yeah, that's true. I'm pretty sure doctors at University of Michigan are much better than me, but I need to be more convinced.
It's just the intra-observer. It can be anywhere. It's nothing.
Okay.
You underestimate yourself, Dr. Alsaati. You're really good.
Yeah, exactly. I don't think we'll find as good as you anyone who is going to teach us. It's
Oh,
you are just you have raised the bar so high
oh, thank
that
you.
now
Don't, don't,
that
don't,
now
don't, don't let me believe in myself. Wait, wait. I have to always doubt myself to get better. Okay, cecum, and this is granular cell tumor. Okay, so let's see what we have in the cecum. Beautiful. We have a colonic mucosa. We have expansion, a lot of expansion of the lamina propria or submucosa. Basically, no, it's the submucosa. And what comes to my mind here? Okay, my multiple things. Okay, so looking at it on higher power like that, I want to make sure, okay, now that I see very, very much and I have the diagnosis of granular cell tumor right in front of my face, I agree with granular cell tumor, but what else would I do? I would do multiple things. I would do an S100, I'll do a Desmond or an SMA, and I'll do a CD117 or a DOG1 because just can look like anything, okay? And this is what it is. It is going to be all S100 positive. It's a very, I like granular cell tumor. I had a case of a breast when I was in my fellowship with, which had a granular cell tumor, which was very, very rare. So since then, I just love this tumor. It comes to my mind all the time whenever I see stuff like that. Okay, what else? Is that the granular cell? Okay, there's another granular cell tumor of the esophagus, and hopefully we have an S100 here. So this is an esophageal biopsy. And okay, this is very beautiful, isn't it? This is actually very beautiful because at low power, you feel like you're looking at the muscle in the submucosa or something, but then you look further and you see, you know what, there's something wrong in the cytoplasm. There's like granularity, evacuation. Yeah, so that was cool. And I'm hoping that they said there's a polyp for us to look, you know, harder on these biopsies and not just glance really quickly on them. So if they said that there is like a bump or something, you will have to keep an open mind to see further. And this is the S100, and there it is. Okay. And it doesn't look like a schwannoma. So between the S100, between the granular cell tumor and a schwannoma, I mean, they're both going to be S100 positive, but pretty much you have to depend on histology to differentiate. Okay. All right, nice cases. Stomach, gastric marginal zone B lymphoma. Lymphoma, ladies, you want to go ahead and take care of it? I mean, I can. I can start with my H&E, but when it comes to the rest of it, I will just tell me what to do, or if you want, I can give you the driving of it. But we have here.
that's okay.
Okay, so I will walk. I mean, for me, when I do marginal zone, I only am comfortable diagnosing it when the patient has an established diagnosis before. Otherwise, I call it atypical lymphoid proliferation. Hematology will be consulted. Yeah, I always do my cyclin D1 too. Well, I feel good that the stains that I order are the same stains that are here. So, okay, so this is my H&E. Okay, it's definitely atypical. And I'll walk you through it the way I go through it, and then you guys fix me, okay? Because maybe I'll learn something, not maybe, I'm pretty sure I'll learn something of how to handle my marginal zones and whether or not to order molecular every time I get them and so forth. So, so this is definitely not just a band-like lymphocytic proliferation underneath the mucosal surface. It is basically more expanded. The lymphocytes are growing in a sheet-like around and above and beneath. one thing we have to look for is the lymphoepithelial lesions, which we have them right here, where the lymphocytes disrupt the mucosa, and they kind of eat up the glands. So they're actively destructing the glands. So this is a nice criteria for to raise the suspicion of lymphoma in these cases. And the other one here, you have your lymphocytes also very deep. I don't know even if that's a criteria or not. So you will go ahead and order stains. That's my
that was a good one.
Okay.
I mean, you identified lymphoepithelial lesions. That's good. And plus, you don't see follicles in there. Like, it's more of a monotonous population. If you see, you don't see any germinal center formation. When there is a germinal center formation, it becomes really hard. But over here, you really don't see the germinal center formation. All you see is monotonous small lymphocytes that are destructing the epithelium.
Yeah. Okay. So now my panel is CD3. CD20.
And those, if you go back to those lymphocytes, to those lymphocytes on higher magnification. So you see on higher magnification, they are like having condensed chromatin. They are somewhat irregular in shape. So that's also something that should be kept in mind, that they will be kind of irregular, though monotonous, but irregular in shape, and with condensed chromatin small.
Okay.
There is another thing that comes like that often involves the GI is the diffuse large B-cell lymphoma, and obviously it will look very different than this because it will look much uglier, and it will look and then you do the Ki-67 as well as a part of the panel too.
Okay. So now we're looking at CD20 and CD3. So oops. So this is CD20. And my CD20 is pretty much very strong.
And then the other thing to notice is that you don't have that follicle that I was talking about. It's all diffuse CD20 that is positive.
Yeah. And this is my CD3, which I see that it's very, very strong too.
Yeah, but then you should not have as much CD20 as you saw in there. So you should not really have those many B cells in there.
So even if you have this much CD3, it's okay?
Yeah.
Oh my God. Okay. So CD3, CD20, CD43. Now CD43 is positive in CD3 T cells and in neoplastic B cells. Correct?
That's correct. Okay. That's correct. And CD40. CD43 is a soft sign. We do it on marginal zones very often, and if positive, it would support the diagnosis.
Yeah, but now how can I tell if there is B cells that are positive?
Yeah, so I mean that will be hard to ascertain based on what we saw in the CD3 here. So I won't blame you if you can't tell.
Okay. Now CD5. It's a T
cell. CD5 is staining the T cells here.
Yeah.
So we know that they will be positive for CD5.
Okay. Cyclin D1. Okay, I know it's not mental. And then, so that's it. So he is basing his diagnosis on what? That's what drives me crazy in this case.
Well, you should not see so many CD20 B cells in such a prominent lymphoid aggregate. Second, the lymphoid aggregate is not having any follicular formation. Third, they are monotonous. Fourth, there is lymphoepithelial lesion. So all of that, there is CD43 as well. So all of that would make it.
So would you send it for molecular?
One more important thing is in heme. Most of the times it is a comparison, like in the sense like how many like CD3 positive cells are there, whether the CD5 positive cells are similar, like numbers more or less, or it is more than that. And that's how you compare. And 43 is one of the stain where if you are having, it is the numbers wise, if it is same as the B cells, then you know that it is aberrant expression. Otherwise, T cells will have 43 expression.
Yeah, exactly. That's the thing. So we have a CD43, CD5, and CD3 staining the same cells, which are T cells. Correct?
And That's correct. And it's hard to tell whether those CD43 cells, some of them are B cells or not, because usual cases you would not have as many T cells as you see in this case. Usual cases will have less number of T cells usually, but then the tumors don't always read the books, of course.
No, the most thing that makes me lean towards mild lymphoma in this case, based on H&E, purely on H&E, is basically the diffuse pattern. And I know that this, and I have very minimal activity, so I don't have the blamer, which is the H. pylori gastritis, number one. So there's no reason for all of this chronic inflammation to be in the background, and the destruction of these these glands by the lymphoepithelial lesions. So I know that this is more of a neoplastic process, and they're eating up the glands. So just for those who are non-heme and who are listening to us right now, it's just don't be shy of sending it out. If you're in doubt, send it out. That's my of always. When you're in doubt, send it out. Let other people. We are treating the patients based on these stains and thought process. So do your best. But if it's, I mean, I am totally not expert in heme, totally. So I basically told you I do not send I never sign out heme cases for GI unless I actually have an established diagnosis and I see my lymphoepithelial lesions. Of course, I do my panels.
And if you have a hematopathologist in your group or in your institution, just let them deal with it. Exactly, just okay, exactly. This is not my case.
I know, exactly. Exactly.
Yeah. That's one less case for you, right?
Exactly. Pneumatosis cystoides. Ladies, I hope you remember that. We looked at it before. Oh, wait, hold on. Why did I just move down? Okay, fundogland polyp with low-grade dysplasia. Okay, again. The reason they have it there is just to remind you girls, when you see fundogland polyps, which is probably 5 or 6 times a day, always clean your epithelium for low-grade dysplasia, okay? Don't let it go by as if there is nothing going on. And I'll show you where my low-grade dysplasia is. The area that bothers me the most is this area here. Right there, the epithelium is becoming more stratified, reaching the top. Same here. Let me see if I have better. Okay, right there. Okay, your epithelium is becoming more stratified. See how the nuclei are coming up? Okay, the importance of whether or not there is dysplasia in these cases are as follows. If the patient is younger, okay, this patient has to have colonoscopy done, because patients with low-grade dysplasia in fundogland polyps or in gastric polyps are of high chances to have colonic adenomas, okay? So that's why you kind of put there, you say this is low-grade dysplasia arising in a fundogland polyp, see comment in the comment section, given the patient's age, recommend colonoscopy, because in some patients you'll have, they're at more risk of adenomas or cystal adenomas. Or if it is at older age, 60 and above, you would say low-grade dysplasia present in a fundogland polyp, although these can be as seen in patients with low-grade adenomas. However, this is criteria seen in younger patients, and it's no significance in this patient's group. Okay, so you don't have to have the doctor worried about tubular adenomas in those cases. Okay, so the beauty of having a complete GI report is before you put down your information in that report, remember the consequences, remember the follow-up years, remember the correlations with genetics, correlations with family history, correlation with a prior endoscopy. We'll see here, pneumatosis. I'm really wanting to jump to pneumatosis intestinalis. I will wait.
Before you do that, I want to remind you of the time. It's 5:17.
Oh my gosh! Oh my gosh! I really have to go. I really have to go. But I'll do one more.
Yeah.
I'll do one more. Oh gosh. Okay. So pneumatosis cystitis. So pneumatosis is air. So where are we now? Okay, it's lagging. It's not so, what is this? Lots of EOs here. And lots of spaces, but I don't have my classic foreign body macrophages. I don't have it. Okay, let me tell you what I'm looking for. I'm looking for air-filled spaces surrounded by foreign body giant cell reaction. Okay, which I'm pretty sure it's here, but now that I know that I have to go, I am going faster and then I'm not thinking properly. But I'm assuming it's somewhere around these areas. I will look at it again and I'll go back to it tomorrow, but let me show you the more classic one. Intestinal. Look at that.
This one is really
so beautiful, so beautiful. So you have a lot of cystically dilated spaces. This could be iatrogenic, this could be whatever, but once you look at the lining of these cells, you will have foreign body giant cell reaction, which I don't see here. But I'm pretty sure, well, the foreign body giant cell reaction happens because of its chronicity and the body is trying to react to it, but I don't see it here. This one, you can just call it pneumatosis intestinalis. Let me see this area here.
So on the top line, you call it pneumatosis intestinalis. You don't say anything in the comment.
No. And then I will say no dysplasia in the top, chronic active or chronic or microscopic colitis. That's how I would call it. But listen here, and I can do a microscopic description, and I would say that there is some cystically dilated, open coat, air-filled, closed coat spaces in the submucosa with surrounding blood vessels. Some areas may show reactive foreign body multinucleated giant cells because it's not very prominent here, okay? I don't see the reactive changes here as much. But this is non-significant. And then the doctor will tell you that it looks to him like pneumatosis intestinalis. And you see, this is consistent with the clinical impression of pneumatosis intestinalis, okay? That's it. Pneumatosis cystitis. I'm not sure if this is that a parasite? Okay, I will look at it tomorrow and I will talk to you about it. So, tomorrow, I don't know, Akanksha, let's touch base and see what my tomorrow is like, okay?
Yeah.
Well, I have a meeting tomorrow. I have a meeting 2:30 to 3:30. I cannot do it.
Yeah, we'll talk about it when we can do,
okay.
When you are available. Okay.
Okay. All right, ladies. Take care.
All right. Bye-bye.
Bye-bye.